Well, good afternoon, everyone, and welcome to the JMitra Scientific Webinar on Malaria Diagnostic Modalities and Challenges. It is a pleasure to have with us today Dr. Agnijit Palit, Consultant, Department of Microbiology, Apollo Hospital, Lucknow. Dr. Palit brings a valuable clinical and laboratory experience in microbiology, and today he will be sharing his insights on the diagnostic approaches used in malaria, along with the practical challenges faced in accurate and timely diagnosis. We are quite confident that this session will be informative and useful for all participants, especially for those working in diagnostics, clinical laboratories, and healthcare delivery. With that, I warmly welcome Dr. Agnijit Palit and hand over the session to you. Over to you, sir.
Thanks a lot for inviting me as a speaker on this topic. Uh, my name is Dr. Agnijit Palit. I am a senior consultant in the Department of Microbiology at Apollo Medicine, Lucknow. And today we will be discussing on the diagnostic modalities and challenges for malaria. And as we had the World Malaria Day a couple of days ago, so this will be our effort to suggest the steps to ensure accurate and timely parasitological confirmation for global elimination efforts of malaria. So coming straight to the topic, what is the global burden and the scale of the challenge? So it is estimated as per 2022 statistics that globally around 249 million people are affected with malaria and 608,000, that is close to 6 lakh 8,000 people have died due to malaria. Accurate diagnosis is the cornerstone of malaria management, and without it, the world risks the development of resistance and undetected transmission. So, coming to the malaria parasites, malaria is caused by a parasite of the genus Plasmodium. So, there are about 156 named species which infect vertebrates, of which only 4 are known to infect humans. These are Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, and Plasmodium ovale. Now, Plasmodium vivax and malariae, they cause more than 95% of the infection. There is another Plasmodium known as Plasmodium noalesi, parasite of monkey. But nowadays, there have been reports of few cases of Plasmodium noalesi infection, especially from some parts of Asia. Distribution, Plasmodium falciparum is usually distributed in the tropics. Plasmodium vivax has the widest distribution in tropics, subtropics, and temperate regions. Plasmodium malariae causes sporadic infections, and Plasmodium ovale is extremely rare, but in common in western part of Africa. In India, mostly Plasmodium vivax and falciparum cause the majority of malaria infections. There have been few cases by Plasmodium malariae and Plasmodium ovale. What is the vector for malaria? The vector of malaria is the female Anopheles mosquito. There are about 45 species of Anopheles mosquitoes in India. However, out of which few are important with regards to malaria transmission. These are Anopheles stephensi, found in urban areas, Anopheles flaviatilis in hilly regions. In rural areas, Anopheles culicifacies is the major culprit, and there are other similar species like Anopheles minimus, Anopheles philippinensis, Anopheles sundaceus, and Anopheles maculatus. Now, coming to the life cycle of malaria parasite, malaria has a complex life cycle. So first we see what is the host for malaria. So there are two types of host in parasitology, as we say. One is the definitive host and one is the intermediate host. Definitive host is the host where either the adult parasite lives or sexual reproduction takes place, and intermediate hosts are those hosts in which the asexual phases live. In malaria, intermediate host is man and definitive host is the female Anopheles mosquito. Infective form is sporozoites. As we can see, when an infected female Anopheles mosquito bites a human being, sporozoites pass through the bite into the blood. They travel to the liver. in the liver, they undergo what is known as exoerythrocytic schizogony. I will be talking about this schizogony in the future slides, but just in short, in the liver, after the exoerythrocytic or the hepatic schizogony, merozoites are released into the bloodstream, which infect the RBCs. Into each RBCs, each of these merozoites form trophozoites. These trophozoites again undergo what is known as the erythrocytic schizogony, and once mature, they rupture the RBC membrane and release merozoites into the blood, which infect fresh RBCs. Some erythrocytic schizogony also result in the formation of gametocytes or the sexual forms, which are again picked up by the mosquito during their biting of the susceptible person, and thus the cycle continues. So, as I have said, there is a primary exoerythrocytic stage or pre-erythrocytic schizogony. There is a erythrocytic schizogony. There is a gametogony, and there is also a dormant schizogony, which results in what is known as relapse. This is in short the cycle which is described in the picture. Man obviously is a part of the asexual cycle. You can see the sporozoites entering the liver, undergoing pre-erythrocytic schizogony, and they form what are known as hepatic schizons. They rupture, releasing merozoites, and these merozoites infect RBC. Once inside the RBC, the once the merozoites enter the RBCs, they are known as the early trophozoites, which are also known as the ring form. This ring form later then matures, forming immature schizont and mature schizont, and ultimately the RBC ruptures, releasing the erythrocytic merozoites, which again infects the fresh RBCs, and thus the cycle continues. And parallelly, some product of this erythrocytic schizogony also results in the formation of gametocytes. As you can see, male and female gametocytes, these are picked up by the mosquito during their blood meal, and they undergo fertilization in the midgut of the mosquito, and they form what are known as oocysts. These oocysts, once they mature, they release sporozoites. These sporozoites then enter into the human being through the bite of the mosquito. Now, coming to the pre-patent period, this is uh, by definition the time interval between the entry of the parasite into the man and demonstration of parasites in the peripheral blood. So, ring forms, as I have said, are the first asexual form that can be demonstrated in the peripheral blood. The pre-patent period in Plasmodium falciparum is 5 days, in Plasmodium ovale is 13 days, in vivax it is 8 days, and in Malaria it is 9 days. Malarial pigment. Now, these Plasmodium parasites, they feed on hemoglobin, which is present inside the RBC, and the undigested product of hemoglobin metabolism, like the hematin, excess protein, and iron porphyrin, they combine to form what is known as the malarial pigment. This malarial pigment color is slightly different for different these species. In vivax, it is yellowish brown. It is dark brown with 1 to 2 solid blocks in falciparum. In Malaria, it is dark. It is dark brown with coarse granules, and in oval, it is dark yellowish brown, coarser than that of Plasmodium vivax. Early trophozoite, as I've said, early trophozoites are the ring form. So, if we see the morphology of the ring form in Plasmodium vivax, they are large, 2.5 micrometer in diameter, usually one chromatin dot and occasionally two chromatin dots. In Plasmodium falciparum, it is small, delicate, 1.25 to 1.5 micrometer in diameter with two chromatin dots. In Plasmodium falciparum, we often see what are known as the acoliform, that is multiple ring forms within a single RBC, and they lie on the RBC membrane like this. Malaria and oval morphology of the trophozoites are similar to that of Plasmodium vivax. Now, coming to the late trophozoites, so what happens is that once the trophozoites they enter, they are inside the RBC, they mature, they undergo what is known as erythrocytic schizogony, as I've said. So the trophozoites they become enlarged in size and they start multiplying. They undergo schizogony, and each erythrocytic schizon contains numerous merozoites. So in late trophozoites, if we see the morphology in Vivax, it is large, amoeboid, and predominantly vacuolated. In Plasmodium falciparum, it is medium size, compact and rounded. In Malaria, it is small, compact, band-shaped and slightly amoeboid, and in oval, it is slightly amoeboid. Mostly in India, as I have said, we see Vivax and falciparum only. So in Vivax, it is mostly amoeboid, and in falciparum, it is compact size and rounded. If we see the schizons, the morphology of the schizons, as you can see in Plasmodium vivax, the schizons are large. They increase the size of the RBCs, and the diameter is 9 to 10 micrometer. In falciparum, the RBC size is not increased. The diameter fills the schizon fills two-thirds of the RBC's diameter. The RBC itself are not enlarged. In Plasmodium malaria, it is 6.5 to 7 micrometer, almost feels almost normal size RBC. That is, the RBCs are mostly of normal size. In Plasmodium oval, the diameter of the schizons are 6.2 micrometer. It feels about three quarters of slightly enlarged RBCs. So in Plasmodium vivax, as I have said, once this erythrocyte schizon rupture, they release merozoites into the circulation. So how many merozoites in vivax? 14 to 24, in falciparum 14 to 32, in malaria 6 to 12, and in oval also 6 to 12. This is the diagram showing the life cycle in brief, the erythrocytic cycle. So as you can see here in falciparum, I have said there are multiple ring forms or acoliform. So they increase in size, they undergo erythrocytic schizogony. These are the modern clefts, these are the merozoites, and parallelly these gametocytes are formed. These are the banana-shaped gametocytes which are typical of Plasmodium falciparum infection. In Plasmodium vivax, the RBCs are increased in size. These small dots are known as Schuppner's dots, and as you can see, this is becoming more and more amoeboid. As I've told you in the previous slides, the RBCs become filled with the late trophozoites or the schizons, which contains multiple merozoites, and parallelly this gametogony also takes place. So a word about recrudescence and relapse. So I have told you in case of Plasmodium vivax, once the parasite enters into the blood, it goes into the liver and undergoes hepatocytic schizogony or exoerythrocytic schizogony, and they ultimately release merozoites into the circulation. However, there are some cases where some part of these sporozoites, when they enter into the liver, instead of undergoing erythrocytic schizogony and forming what is known as a hepatic schizon, which releases merozoites, some of them they transform into what are known as dormant liver stage hypnozoites. So these hypnozoites, they remain in the liver. They can remain in the liver for multiple times. They can remain in the liver for a long time, and maybe after 9 months, or in some cases of tropical climates at an interval of 3 to 4 weeks, they again enter the cycle, undergo hepatic schizogony, and continue the normal malaria cycle. So this relapse is a typical characteristic of Plasmodium vivax infection, and for this reason we need the treatment of the hepatic hypnozoites also. This hypnozoid phenomenon is not found in Plasmodium falciparum, mostly found in Plasmodium vivax, rarely in case of malaria and oval. So this is known as relapse of malaria, and obviously once these hypnozoites again enter into the cycle and then release merozoites after the hepatic schizogony, exoerythrocytic schizogony, fresh infection of the RBC occurs, and the patient again has symptoms of malaria. So that is why it is essential to treat these hepatic dormant hypnozoites in case of Plasmodium vivax infection. Another term which is closely associated with relapse is known as recrudescence. In recrudescence, what happens is that it is caused by the survival of parasites in the blood due to inadequate treatment, drug resistance, or low drug levels, leading to a return of the same infection. So both in relapse and recrudescence, the symptoms reappear for the patient, but whereas relapse is caused by the dormant hepatic hypnocytes, recrudescence is caused by inadequate treatment, which leads to the survival of the parasites in the blood, leading to continuation of the symptoms. In endemic areas, it is difficult to differentiate between relapse and recrudescence. However, the fact is that recrudescence occurs soon after treatment because the parasites are not killed at all. All the parasites are not killed, and then the symptoms reappear. However, in case of relapse, there is usually a dormant period like 3 to 4 weeks, and in case of temperate climates, it can be as high as 9 months. Now, how to diagnose malaria? So, malaria is one of the few parasitic infections which is considered to be immediately life-threatening and a medical emergency. The cornerstone of diagnosis still lies on the microscopy. And for microscopy, what we do, we collect blood either from a finger prick or ear nodule. We can also collect peripheral blood from a peripheral vein. We usually prepare thick and thin smears. Thick smears are usually for the detection of parasites. They cannot distinguish between species. And for thick smear preparation, we do dehemoglobinization, for which we keep the slides in Coplin's jar containing distilled water. After dehemoglobinization, we make the slide air dry, and then they are stained by Leishman stain or JMitra stain, and under oil immersion field in microscope. This is just a method of preparing this smear. So this is the blood, and we hold this another slide at an angle of around 45 degree, and this prepare this tongue shaped smear. Where will we see the parasites? So parasites are abundant in the peripheral blood, usually late in the febrile paroxysm. So what is the febrile paroxysm? So when this cycle of the malaria parasite occurs in the erythrocytes rupture, releasing fresh merozoites, which again infect other RBCs. So this phenomenon, this causes a lot of inflammatory reaction, including febrile paroxysm, shivering. So in earlier days, we used to say that fever with shivering is a sign of malaria. However, it has been proved that the cause of shivering is the release of the different inflammatory mediators, which can occur in other infections also. So, by the term febrile paroxysm, we mean the conditions where the merozoites are released into the blood, rupturing the erythrocytes. So that releases the inflammatory mediators, and the patient has these bouts of fever and the shivering. So in blood, all the asexual erythrocytic stages and as well as gametocytes can be seen, except Plasmodium falciparum. In Plasmodium falciparum, usually the ring form and the crescent shape, that is, I have shown you, the banana-shaped gametocytes are seen. Uh, why in falciparum the picture is like this? Because in falciparum there is a protein known as histidine rich protein 2, which by the help of which it migrates to the internal organs, and they attach to the internal organ capillaries, so they disappear from the peripheral blood. That is why the uh, trophozoites, the RD as well as the red, they are not visible in the peripheral blood. In case of Plasmodium falciparum, only ring form and crescent shaped gametocytes are present. uh, Malaria pigments, yes, malaria pigments may be demonstrated inside the polymorphonuclear cells, and there are few diagnostic methods nowadays which make use of these hemoglobin pigments or malaria pigment. So presence of malaria pigment in the peripheral blood, but absence of the asexual erythrocytic stages like the ring form, like the like the late trophozoites and schizons, that is an indication of Plasmodium falciparum infection. Because in Plasmodium falciparum, only ring form and gametocytes are present. And as we know, the RBCs are enlarged in Vivax infection, and they are almost of the normal size in case of falciparum infection. So I have told you about two films, thin film and thick films. So thin films are examined first, and in thin films we do not do dehemoglobinization. We see the parasites within the RBC, and in case of thick smear, we actually dehemoglobinize the RBC. Okay, so the parasites come out of the RBCs, and we see along with the WBCs. So the technique is first we see the thin film, and if parasites are found, there is no need to examine thick smear. If parasites are not seen in this smear in a few minutes, then thick smear should be examined. It must be noted that parasites are more along the upper and lower margins of the tail or the smear. So they are more along the upper and lower margins of the tail, and at least 200 to 300 oil immersion fields should be examined before declaring the smears as negative. So as you can see, this is the thin smear, this is the thick smear, and this is the tail portion. So their parasites are more concentrated along this tail. So there is also a provision of fluorescence microscopy where we use acridine orange stain. It allows quicker screening of films because parasites are more readily recognized and the low power lens may be used. As you can see, this is the shining gametocytes which is seen on fluorescence microscope, and the staining is acridine orange. So, how will you quantify the parasites in blood? So, there is something known as CPI, or the clinical parasite index. So, this is usually a quantification of what is the level of parasitemia in the blood. So, it is done mostly by the thick smear. So, we count the number of parasites, and we also count the number of WBC, multiply it by the WBC count of the patient, or by 8,000 if the WBC count is not available. So as the WBC count is given per microliter of blood, so this ratio gives the parasite index per microliter of blood. There is another way also in which we use the thin smear and we find out the percentage of the infected RBC. So these are the two methods by which we can quantify the level of infection. And what is the necessity for doing this? One, we assess the severity of infection, we monitor the response to treatment, and we also it also helps in detecting the drug resistance in Plasmodium falciparum. Coming to the rapid test, the advent of the rapid diagnostic test, or what we know as RDTs, for malaria has actually revolutionized the malaria diagnosis, because microscopy requires expertise, expert people are not available, it requires a longer time. So these rapid tests especially are basically immunochromatographic tests, and they usually target antigens, various antigens. Mostly they target the PF-HRP2, that is the Plasmodium falciparum histidine rich protein 2, which is a water soluble protein produced by the trophozoites and young gametocytes of Plasmodium falciparum. And we also target the parasite lactate dehydrogenase, which is produced by the all the species of the Plasmodium parasites, both falciparum as well as non-falciparum. So these are the two major antigens which we target, and what we do nowadays is that we incorporate two antigens into one test. That is, a single test will detect two antigens. One antigen is usually for the Plasmodium falciparum, that is PF-HRP2, and another is the pan parasite LDH, which is present in all malaria parasites. Now, if only the band for the PF HRP2 and the pan-specific LDH both come positive along with the control band, then this indicates Plasmodium falciparum infection. However, when there is only the positivity of the pan-LDH band and the control band, so this is a non-falciparum infection. So the disadvantage of this is that it cannot differentiate between P. vivax, P. malaria, and P. oval infection. So these are the few rapid diagnostic tests commonly available in the market, and I have written the antigens which are targeted. So PAN plus PF card, it targets PAN LDH and PF HRP2. There is one advantage PF malaria card which targets only Plasmodium falciparum histidine rich protein 2. That is, this is only for Plasmodium falciparum infection detection. This is not suitable for the other Plasmodium vivax and the other non-falciparum non-vivax infection. Then there is pan malaria advantage pan malaria card which detects only the PLDH. So it will have only one antigen target, that is PLDH. So it cannot distinguish between a falciparum and a non-falciparum infection. Then we have this advantage malaria card which has PF-HRP2 and Plasmodium vivax LDH. So this detects mostly Plasmodium vivax infection and Plasmodium falciparum infection. And then there is advantage malcard which uses pan parasite LDH and Plasmodium falciparum LDH. The cause for this I will tell you in the future slides. So this is another example of the rapid diagnostic test available in the market. As you can see, these are the results. So there are three bands. One is the control band, one is the pan LDH band, and one is the PF-HRP2 band. And depending on the which band comes positive, we interpret the results. It must be noted that if the control band does not come as positive, the test is invalid. There is another method which is known as quantitative Buffy code test. So basically, it was developed by Becton and Dickinson. What we do here is that we usually take blood in a capillary tube and then we centrifuge it uh, under a specific RPM, and then we examine under UV light source. The stain used is acridine orange. Other techniques are nucleic acid application tests like PCR or loop mediator isothermal amplification. There are a few commercially available PCR test kits like TrueNat Malaria, PVPF. Serology was earlier used, but it has been discontinued in endemic countries like India because it is highly non-specific. Quantitative Buffy code test. So this was the test I was speaking about. So basically, blood is collected in the capillary tubes containing EDTA, heparin, and acridine orange. A plastic float is used, and the tube is centrifuged, and the parasites are forced into the Buffy coat or the white cell layer, where they fluoresce under a fluorescence microscope. It is highly useful for rapidly screening populations, detecting asymptomatic carriers, and diagnosing low-level infections, often outperforming conventional thick films. However, the limitation is that while rapid, it is generally less effective is in distinguishing between the species like P. falciparum and P. vivax. Nowadays, there are various modifications of these Buffy code techniques, which uses specialized centrifuge techniques so as to improve the sensitivity further. This is the picture of the Buffy coat. Here you can see this is the capillary tube, and there is this precision plastic float. This is the thick layer of red blood cells, and as a result of this centrifugation, these parasites are present in the Buffy coat layer. That is the granulocyte layer, and there is this lymphocyte monocyte layer. So here between them, this is the Buffy coat layer, whereas this is the interface where the parasites are present. There is also a provision of culture, however, it is mostly used for research purposes. Traeger and Jensen, they successfully cultivated and maintained P. falciparum in vitro in human red blood cells. RPMI 1640 was the medium which was used in a continuous flow system. Human erythrocytes were in a shallow stationary layer, and they are covered by shallow layer of the flowing medium, and the medium was flowed slowly and continuously in an atmosphere of 7% carbon dioxide and 1 to 4% oxygen, and now it is widely used for the production of antigen. So there is drug resistance emerging also in malaria. So usually three levels of resistance are there. In R1, following treatment, parasitemia clears, but a recrudescence occurs. Recrudescence, that is the reappearance of the symptoms due to inadequate treatment. In R2, following treatment, there is a reduction, but not complete elimination of parasitemia. And in R3, following treatment, there is no clearing, no reduction of parasitemia. So basically, this resistance categorization is done by WHO, who has to monitor and also help in surveillance of resistance. And as we know that resistance to anti-malarial drugs is fast spreading, and there has been resistance reports from India. Chloroquine-resistant malaria is highly prevalent in India, and if we see the artemisinin derivatives, their resistance is present in the Southeast Asian countries like Thailand, and also have been reported in some parts of Northeast India. So, what are the diagnostic challenges in malaria? So, first, why is diagnosis is necessary in malaria? Because malaria is a life-threatening emergency, especially Plasmodium falciparum. If we don't diagnose it timely, the patient is bound to die. Because as I have said in Plasmodium falciparum, the parasites they migrate to the internal organs due to the presence of PFHRP2, and they clog the capillaries of internal organs, resulting in multiple organ dysfunction syndrome, and the patient can die very quickly, resulting from a lot of problems. There is renal failure, there is cardiac failure. So that's why treatment is essential. Microscopy remains the enduring gold standard, but the problem is that uh, it needs expertise, and it needs qualified doctors, and it needs time also. Antigen detection technology, I have already said, they have revolutionized the diagnosis of malaria, but there is a small problem here, as I have said. In antigen tests nowadays, PF-HRP2, there are some reports that there are PF parasite, Plasmodium falciparum parasites, which have PF-HRP2 deletion. So for that reason, we can't detect the PF-HRP2 antigen. That is why, as I've said, in current kits like what we use nowadays, Advantage Malka told, it uses the PF specific LDH for this matter. Otherwise, it is very difficult to diagnose these cases where there is PF-HRP2 deletion in case of Plasmodium falciparum. Nucleic acid amplification test, I have said, again, the tests are good, but then the problem is that it requires specialized instruments. Coming to the comparison between the tests, in microscopy, the minimum parasite which is required for diagnosis is 50 to 100 per microliter, whereas in the rapid diagnostic test, it is 100 to 200, less than 1 and 1 to 5 in PCR and LAMP respectively. Microscopy is time consuming, as I've said. RDT is 15 minutes, PCR takes 3 to 6 hours, and LAMP is PCR only, but here it is isothermal amplification. That is why it requires less time. The multiple temperature cycling of PCR, conventional PCR, are not present in LAMP. So LAMP is an suitable alternative for PCR, especially when you require rapid diagnosis. Main benefit of microscopy is that it can be used for quantification and species. Rapid diagnostic test, yes, because it can be used by unexperienced people also, and treatment can be started immediately. The problem with RDT is that RDT remains positive even after treatment. We encounter many such cases in our day-to-day life in our hospital also, where the patient has been cured of malaria. There is no parasite visible in the blood, but the RDT tests are positive. So it remains positive for a few months after the clearance of parasites from the blood. So that is a disadvantage. It can give false positive results. So this was the challenge I was talking about, the PF-HRP2/3 gene deletion. Due to this, the majority of the RDTs become ineffective, and it originated from Amazonia and now highly prevalent in the Horn of Africa like Ethiopia and Eritrea. So in these countries, there are quite a few cases where there is PF-HRP2/3 gene deletion. That is why even in India nowadays, we prefer those kits which target the PF LDH like the Advantage Malka. What are the challenges? Number one is the asymptomatic carriage. So many individuals carry parasites at levels below the detection limit of microscopy and RDTs. Thus, they continue the transmission cycle. There is a detection limit gap. Standard RTTs usually fail below 100 parasites per microliter. Molecular surveillance is thus needed to map these populations accurately. And there is this elimination barrier. In low transmission settings, these sharp microscopic infections, they continue, and they continue to transmit the disease, posing problems for the epidemiologists. So, what are the implementation and infrastructure gaps? One is obviously the resource constraints, lack of stable electricity, especially in rural areas, and cold chain logistics. They affect the shelf life of RDTs and the ability to run molecular diagnostics. Technical expertise, yes, I have said that shortage of trained microscopists leads to poor quality smears and misdiagnosis, especially in remote health posts. And there is the operational cost for advanced tests like PCR. So what is the future? What is the future of malaria diagnosis? So one is implementation of digital microscopy, and you combine it with AI, as nowadays we use AI in multiple cases. So automatic scanning and AI algorithms can help standardize the microscopy results. This is coming up in a big way in many centers, and some of the centers have started using this. There are non-invasive methods also. So I have told you in the earlier slides that the malaria pigment or the hemozyme pigment can also be detected. So nowadays there are few techniques which are coming up, still in research phases, not commercially implemented widely, which actually detect this hemozyme pigment through transdermal laser. So there are laser instruments which detect the hemozyme pigment by shining nasal light across the skin, and there are also other methods by which we detect the hemozyme pigment like magnetic detection. We, the help of magnets and specialized instruments, we can also perform the detection of the hemozyme pigments across the skin without the need of pricking the patient. So these are the few which are the upcoming advancements. So all in all, the future of malaria diagnostics, this rests with the advent of the newer techniques like, as I've said, implementation of AI and digital microscopy, and also in rural areas and other resource limited settings, improving the infrastructure so that malaria diagnosis is not a problem even in the villages. And as we know that malaria is endemic in India, and for malaria to be eliminated, this infrastructure needs to be upgraded and newer diagnostic methods needs to be introduced. So thank you all for your patient hearing. I am open to any questions and suggestions. Thank you.
Thank you very much, Dr. Palit. That was very detailed, for a disease that today sometimes it is on the, how do I call it, sidelines, right? Malaria has been
Yes.
sidelined by many. In fact, some states like Kerala, they call themselves completely malaria free. How much of that is true remains to be seen, because that's a statistical thing. But what I have observed is that a lot of, one second, sir, this is, uh, you can just stop the share at your end, sir,
Okay.
because it's putting up picture in picture for me. Yeah. So, in your opinion, where is this? There is a lot of things you talked about, rapids, ELISAs, even for that matter, molecular. Do you really think molecular, given the way malaria is treated in the country in terms of the importance that we give a dengue, we don't give it to a malaria? Both are dangerous, but we don't give it that kind of thing. Do you think molecular or chemiluminescence can be used as technology effectively in the Indian subcontinent, sir?
Molecular diagnostics obviously can be used because it is highly sensitive. Only a disadvantage of molecular diagnostics is that it is costly. So I feel that government needs to upgrade the infrastructure, like government has done for TB. They have provided molecular diagnostic methods to all the centers, as we know very commonly, gene expert. They have provided free of cost to hospitals and even in villages, sub centers and health centers. So I think government can use the same technique for malaria also. If they provide molecular diagnostic facilities in rural health settings, I think that will be a great boon to malaria diagnosis. Coming to CLIA, again in India, because India malaria is really endemic and you can say it is hyper endemic. So in such cases, serological methods, ultimately CLIA is a extension of ELISA platform only. It will detect the antibodies mostly. So here, I don't think it will be much of an it will be of much help because in India, as because it is hyper endemic, so low level infection might be there. That is why positivity of antibodies will not indicate infection. But yes, it can be used as a tool to see the burden of all the cases, including the subclinical cases.
Thanks, sir. There was a question that came in from the audience. I'll just read it out. We observed several malaria positive cases last year, confirmed by both peripheral smear and antigen tests. However, in some instances, after completion of the anti-malarial treatment, patients continue to show antigen positive results, while the peripheral smear study was negative. These patients also did not exhibit any clinical symptoms. So we would appreciate your guidance on how to interpret such cases and the appropriate follow-up protocols, sir.
Yes, this is a very good question. I spoke about this briefly also during my presentation. In my tenure here in Apollo over the last 6 to 7 years, there has been at least 10 to 12 instances of such phenomenon where the antigen tests are positive, the patient is asymptomatic or the patient had a past history of malaria which was treated. So here the first step will be to do the peripheral blood smear. C. Repeat it if two or more peripheral blood smears are negative but the antigen continues to be positive. Then go to the patient, take a proper history. There might be two possibilities. One, the patient will give a history of malaria treatment which has been completed, or the patient will not give any such history. So in the case of the patient giving a proper history of malaria, we have just to ensure that whether the doses were completed properly, A, to what was the species, whether it was Vivax or whether it was falciparum. In cases of Vivax, we know that there is a condition which is known as relapse. So we have to inquire whether primaquine treatment was given to target the hypnozoites. If that has been given in cases of Vivax species, I don't think there is any further treatment which is required because antigen will be positive for close to 6 months post treatment, maximum 6 months. The second category of patients will be those patients who will not be able to give any history of such malaria treatment. So I will feel that in such cases, there mostly these are the cases of subclinical infections. So what we do as a precaution in our institute, that if the patient does not give any such past history of fever or something like that, and the patient has a current fever, because obviously if the patient does not have any fever, why will we do the malaria test? So the patient is having currently fever, the patient is febrile, the patient does not have any past history of some malaria treatment or something like that, and the parasites in the blood, that is through microscopy the result is negative. So in such cases we treat the patient like a malaria positive case. Why? Because as we know that untreated malaria cases can be dangerous, even fatal in some cases. That is why in such cases where the patient is having fever but does not have the smear positivity and does not give any history of past history of fever with some treatment by anti-malaria agents, we treat the patient as a malaria positive case.
Thank you, sir. There was one more question about from another person here saying why falciparum is called tertian malignant malaria.
Yes, so the term malignant comes from malignancy. We all know that in cancer we use this term malignancy. So malignant malaria comes from that. That is, it is fulminant. It is severe. That is why it is also known as malignant malaria. So what is malignant malaria basically? It is falciparum malaria only, but it is known as malignant because, as I have said, the parasites migrate to the internal organs, they clog the capillaries, resulting in ischemia and resulting in multiple organ shutdown. So, you might see a Plasmodium falciparum malaria patient presenting with acute renal failure. Renal failure is very common. And once renal failure occurs, there are multiple other abnormalities, raising of the creatinine, the patient has dyselectrolytemia, hyperkalemia, leading to cardiac arrest maybe. So all in all, there is a picture of multi-organ dysfunction syndrome, and it is also known as cerebral malaria. Why? Because some of these parasites they migrate to the brain also, and they affect the brain. The patient might be the Glasgow Coma scale. If we see for the patient, it will appear that the patient is blunted, not responding. The patient is delirious. So all in all, this is a very serious picture. That is why I am saying repeatedly that Plasmodium falciparum malaria is not treated on time, the patient will die. The patient will definitely die. It has a very high mortality rate. So for all these reasons, it is known as malignant malaria or fulminant malaria.
Perfect. Thank you, sir. And thank you very much for your attention to detail. You've covered past, present, and the future of malaria diagnosis. And let's hope that on this World Malaria Day, we can bring it back into highlight that malaria may be a little on the down, but it's not gone away anytime soon, especially with the country as that, where global warming is on the rise.
Yes,
Thank you,
yes.
sir. Thank you very much, doctor.
Thank you.
And thank
Thank
you
you
all
very
for
much.
joining us today. Again, apologies for the delayed start, but I think we had a good presentation once we got started. Thank you, everybody.
Thank you.